Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on Nocardia species under the section of infectious diseases. So this is a picture of Nocardia. It's not too common for slides and histology slides to be examined on your membership. However, as part of the Part 2 written examination, they are completely within their rights to give you a picture of this and ask you to identify it. So I would have a rough idea about some of the key features of different bacteria and species. In terms of its epidemiology, it is found in soil. It is a rare disease, although there is an increase in incidence in immunocompromised individuals, such as those living with HIV and AIDS or cancer, or those patients who are taking immunosuppressant drugs. It affects men more than women. In terms of its detailed pathophysiology, Nocardia is a gram-positive, branching, rod-shaped bacteria. It's partially acid-fast. It is found in soil, decaying vegetation, and water. It's an aerobic actinomyositis, which causes nocardiosis, which essentially we will cover in future slide, but it's a disseminated disease mostly affecting the lungs, brain, and skin. The transmission of nocardia is primarily through inhalation of dust, contaminated soil, or water. However, can also enter through broken skin, leading to cutaneous nocardiosis. Once this is inhaled, it can cause pulmonary nocardiosis or disseminate to other parts of the body, such as the central nervous system. It could have a wide range of clinical manifestations. If it affects the pulmonary system, it results in cough, fever, chest pain, and occasionally blood-stained sputum. If it affects the cutaneous system, it very much resembles cellulitis with pus. It could even form abscesses or cause ulcerations. An example of this is a Madura ulcer or a Madura foot. That is a classic example of nocardiosis affecting the cutaneous system. The disseminated nocardia can affect the CNS, leading to brain abscesses. And symptoms may include any abscess in the brain that you would be probably more familiar with, such as headaches, seizures, fluctuating GCS, and confusion. So in terms of diagnosis, really the most important thing is taking a thorough history and completing a clinical examination, paying attention to the risk factors that we discussed earlier that would put a patient at risk of having nocardiosis. It is confirmed via microscope examination of stained specimens, particularly modified acid-fast staining. You would be able to culture any sputum or skin lesion or performing a lumbar puncture to get CSF depending on the presentation of the patient. And of course, as mentioned earlier, like any other abscesses, if you're suspecting a lesion in the central nervous system, you would want to be opting for your CT or MRI scan of the brain. The management of nocardiosis really is surrounding 3 antibiotics, including cotrimoxazole, amikacin, or imipenem. Treatment can be 6 months to up to a year, depending on the site of the infection and the immune status of the patient. So somebody who is significantly immunocompromised for any of the reasons that we discussed earlier, and for instance has a central nervous system abscess secondary to nocardiosis, is going to have and need the treatment much longer compared to somebody who has got, for instance, cutaneous nocardiosis only without any compromising of their immune system. Surgical intervention may be sometimes required, especially if you are dealing with draining abscesses. Okay, let's do a question. A 55-year-old man with a past medical history of kidney transplant is diagnosed with Nocardia asteroides pulmonary infection. He is currently on cyclosporin and prednisolone. Which antibiotic regimen should be initiated? The options are A, intravenous vancomycin, B, oral doxycycline, C, intravenous amphotericin B, D, trimethoprim sulfamethoxazole, E, intravenous ceftriaxone. If you guys recall, the first option to treat Nocardia species, which is the case in here in an immunosuppressed patient due to taking immunosuppressive medications for their kidney transplant, is cotrimoxazole. And cotrimoxazole is option D, which is trimethoprim and sulfamethoxazole. Thanks for listening to this episode of Bite Size MRCP. If you like what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.